Okay. Hide meeting controls, minimize that. Okay, cool. Let me just start by saying I try to record most of the things that I do, with occasional just me forgetting. That being said, I do post these on my YouTube channel because I think it's just easier for you guys to see them that way rather than having to go through the M Drive and Panopto and stuff. So all my stuff is on my YouTube Nicole Cipriani channel. I've got head and neck stuff, I've got bone and soft tissue stuff, I've got boards review, I've got a lot. So just go there if you ever are looking for something to study. And so today we'll kind of start with an overall overview to soft tissue tumors, how to look at cells, right? How to understand cell morphology, architecture, nomenclature, immunostains, things like that. All of this is in this presentation. We're not going to get through it, right? So we'll stop at an hour and we can sort of, please stop me with questions as we go along. And we can sort of play as we go in terms of how far we get. So for every mesenchymal, sarcomas are rare, right? But benign lipomas, et cetera, are common. So we want to be able to sort of, by looking at demographics, looking at location in body, and looking at basic kind of morphologic pattern group, kind of sift these things into our sort of differential diagnostic frameworks, right? We always want to think about things like age, sex, potential underlying genetic syndromes. We see a lot of NF1 patients, right? So we see neurofibromas, things like that. Was there any prior pathology? Was there any prior radiation therapy? Where is this in the body? Is it in the soft tissue of the trunk or extremity? Is it superficial or deep, generally being intramuscular or subfascial planes? Is it within the abdomen or some other body cavity like the thorax? Or in the retroperitoneum, right, which somebody sometimes says abdomen, you don't know if they're talking about abdominal wall, abdominal viscera, or abdominal retroperitoneum, right? All of those bring up different differentials. Is it within the parenchyma of a visceral organ? Is it in the head and neck, right? Because that's also kind of considered a deep space. Or, once we get to the bone section, right, is it in bone? Which bone is it? A bone that has undergone intramembranous ossification or endochondral ossification, right? Remember that your skull bones, your flat bones are intramembranous and your long bones are endochondral, and those result in different pathology. Is it in the marrow or the cortex? Is it in the epiphysis, the metaphysis, the diaphysis? All those things sort differently, right? So it's just kind of things to think about when looking at a case. And then, of course, what is your basic morphologic pattern? And we'll get into that. For soft tissue tumors, right, benign are way more common than malignant. Mostly we're dealing with superficial things that are benign, i.e. lipomas or neurofibromas, right? And mostly they're small. There is this intermediate category in the WHO now. So not everything is benign, right, and not everything is malignant. This intermediate category of locally aggressive and recurring, or very rarely metastasizing, right? Like most often than not, you won't have a metastasis, but very infrequently you will. So we don't really want to overtreat the patient, but we want to be mindful of clinical observation and management. And then in the malignant category, we've got all of our sarcomas, right? So our sarcomas are generally deep and most often sort of on the extremities or sort of superficial, I guess, deepish trunk. Of course, retroperitoneum with things like deed and liposarc, okay? About 10% are thought to already have met-site presentation. So mostly 90% of cases, right, you're dealing with a core biopsy that you have to make the decision, is this benign or is this malignant? So based on that core biopsy, right, the patient may or may not get neoadjuvant chemoradiation if it's some kind of high-grade sarcoma. They may just get upfront resection. But in all cases, they generally will get surgery, right? Whether it's surgery before chemoradiation or after chemoradiation, surgery is mainstay of treatment for mesenchymal things. Mesenchymal tumors, right, are named according to what they differentiate towards. So we don't think about cell of origin anymore. Like, oh, did this arise from a vessel? Did this arise from a muscle? No, it arose from a mesenchymal stem cell, but what does it differentiate towards? Nothing, like a fibroblast, which has no immunophenotype, so kind of undifferentiated or fibroblastic. Adipocytic, right, liposarc, smooth muscle, lyo, things like that, right? So these are your most common list of malignant mesenchymal neoplasms, with undifferentiated sarcoma being the most common. We see a lot of liposarcs here from the retroperitoneum, sometimes leiomyosarcomas, myxofibrosarcoma, as we'll see in the extremities, synovial sarcoma in young people, malignant peripheral nerve sheath tumor in our neurofibromatosis population. All right, just to get the words out there. Don't worry, we'll get through all of these. All right, most are sporadic, fine. Some are syndrome associated. Few are radiation induced. So every part of the body that can get a tumor, people can get radiated for tumor. And what can happen after radiation, of course, they can develop another tumor, right? So this is on average 10 years after radiation and diagnosis, but can be less, can be more. It's thought that they need probably at least 50 gray of radiation in that site. Usually we're dealing with something like undifferentiated sarcoma in our soft tissues or our head and neck region. Sometimes, of course, we're dealing with angiosarcoma, like in breast or in other skin sites. In patients who already have an increased risk for tumors like retinoblastoma syndrome, Li-Fraumeni syndrome, neurofibromatosis patients, they already have an increased risk for sarcomas. They can then get radiated for their sarcomas. Then they have an extra increased risk for radiation-induced sarcomas because they already have bad genes, right? So you may, when you guys now present at tumor boards, you may hear this discussion of, oh, they already have a syndrome. Should we give them radiation or not? Because like you are potentially causing yet another tumor in these people. So just kind of something to think about, really interesting clinical discussions, right? Hopefully, now that we have this month-long rotation, you see the tumor board, right, for 4 or 5 weeks in a row, and you begin to learn these patients and understand the clinical decision-making process that happens over the course of weeks, not just like kind of you're diagnosing these cases, right? So hopefully this month-long rotation, plug can give us a little bit better kind of overall clinical picture of a lot of these cases that you see from start to finish and through the clinical discussion. Like I said earlier, surgery is primary therapy for mesenchymal tumors. If these are high grade or in an anatomically challenging site, they may get chemoradiotherapy prior to surgery. Many just undergo primary resection, and then additional adjuvant chemoradiation is determined by what we say, right? Margin status, grade, all that good stuff. Books that I advocate include the histologic pattern book, initiated by Hornick, I think is great. I think it's in the 2nd edition now. It's like, if you don't know what you're looking at, because half the time I don't even know what I'm looking at, right? What am I seeing? Can I describe what I'm seeing, and can I find that chapter in the book and go to the differential, right? So it doesn't say, here are all the adipocytic tumors, because you might not know you're dealing with an adipocytic tumor if it's not forming fat, right? So it looks highly cellular and spindled, it looks myxoid, it looks paucicellular and collagenous. This is great. Then hopefully many of you have access to we all have access to the WHO online now, don't we? So love that, right? At your tip of your fingers, it's got everything in like short bullets. It's got virtual slides now, which I think is really cool for studying purposes. So WHO is good for that. I know you all have access to Expert Path. I think with the department as well. The giant Enzinger and Weiss book is also really good if you like a textbook. I'm just gonna plug one thing I was gonna say about Expert Path. I will be editing in the future the head and neck section of the expert path. So if you guys come across questions or see things that you like or dislike or want changed, let me know because I can change it. Okay. So that's for the head and neck section only for expert path. Okay. Otherwise, lineage of differentiation, histologic pattern, and then we put it all together, right? Because we have grades. Okay. So lineages of differentiation include things like adipocytic, fibroblastic, myofibroblastic, quote unquote fibrohistiocytic. What this really means, I don't know. Basically fibroblastic with some associated histiocytes. Smooth muscle, skeletal muscle, perivascular myoid, muscular neoplasms, vascular, chondro, osseous, nerve sheath, undifferentiated. Undifferentiated also kind of being similar to fibroblastic. Like a fibroblast is a cell that doesn't stain for anything, essentially. So is an undifferentiated tumor cell. Histologic pattern, right, can be spindled, can be epithelioid, can be wildly pleomorphic, plump round cell, biphasic, meaning kind of epithelioid and mesenchymal, certainly with various stromal patterns. So what we need to do when we have a biopsy is certainly first determine whether something is neoplastic or not, right? Is this a scar? Is this, could be some kind of reactive inflammation next to a tumor or not even a tumor at all? Things that we thought were reactive, like nodular fasciitis, right? Nodular fasciitis rapidly grew after trauma. It stayed for a while. It never got bigger than a couple centimeters, and then it often regressed. So people thought nodular fasciitis was a reactive proliferation. Well, at some point, right, USP6 gene rearrangement was identified in nodular fasciitis, and now we know it's neoplastic, right? It's a self-limited neoplasm, but sometimes our line between reactive and neoplastic isn't often clear, but we do the best that we can with the knowledge we have today, right? So just kind of my little philosophical undertone. If it's a neoplasm, is it benign or malignant? If it's malignant, generally low versus high grade. According to the French grading system, which we'll see, there are 3 grades. But for soft tissue tumors, grades 2 and grade 3 are essentially considered high. So it's basically low versus high. With low-grade tumors, generally resection with clean margins and watchful waiting. With high-grade tumors, either, again, depending on site, et cetera, they'll undergo chemo and then resection, or just resection, right? And Dr. Hayden, now at Tumor Board, you'll hear whenever someone's had chemo, he's always like, what am I looking for? I'm looking for how good did we treat it, the extent of treatment effect, what's the residual, stage, if anything, and what's the margin status. So treatment effect, margin status, right, which kind of all plays into stage. If it's just resected, they then want confirmation, certainly of whatever grade we may or may not have given it on biopsy. And of course, margin status, always margin status, which might determine need for adjuvant therapy. If something has undergone neoadjuvant chemo or radiation, grade is not accurate, right? So we try to grade as best we can on biopsy because morphology can change wildly after treatment. So post-treatment grade is not fully a great indicator. But naive grade is. Yes, it can sometimes even be hard to distinguish benign from low-grade sarcoma. So again, we kind of do the best we can. We sometimes use ancillary genetic techniques to determine if something has a sarcoma-defining gene rearrangement. We do the best we can. Margins. When you are grossing these soft tissue tumors, right? Sometimes they come with an ellipse of skin where like the biopsy tract was. Certainly with bone tumors, they always take out the biopsy tract just because they think there might be seeding. So the skin is generally just biopsy tract plus surrounding, and you may or may not have some kind of oriented thing. I like to say, when we talk about grossing, I know that in breast, right, if you have a lumpectomy or whatever, even if you're not submitting every single slice within the lumpectomy, you are submitting all of the margins that you perpendicularly section on the medial and lateral. Is that right? Mostly? Okay. Because there's been this, I just need to say this because there's been this trend for like skin or soft tissue tumors to entirely submit the polar, right? The polar end margins, even if you're not submitting the entire main specimen. I don't see a point to that because it's not like we're looking for microscopic DCIS or something, right? You've got a sarcoma and you see the borders of it. You see it. So when you're submitting margins, if you're not submitting the entire specimen, if you're submitting the entire specimen, fine, submit the entire specimen if it's small. If you're not submitting the entire specimen, you only need representative margins from all the different circumferences, right? There's no need to randomly submit all in this end and in this end because you're just wasting tissue, especially if you don't actually see tumor near or close to those margins, or you do see tumor near that margin, just submit the closest, right? You don't have to submit everything. So that's just my like meaty pet peeve on these. You can be selective, right? You can be selective in what you submit as margins as long as they are, unless otherwise discussed with the faculty, perpendicular, right? So you can see distance of tumor to ink, and representative at each site, right? Up, down, left, right, front, back, right? You always think of your six-sided sort of box, right? When you're submitting a specimen. And I know that specimens can have complicated geographic planes and things like that, but if you always think about every corner and every side of your box and whatever representative thing is close to that, you should be fine. Okay. Always, 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 of course, ask us, of course, call us. As you know, we will go over there or we will call you, whatever. Always call us. Okay. Off my soapbox. What else is important with margins? Fascia. So a thin but present fascial plane between tumor and margin is an adequate margin, and they will often ask, because if you say, oh, at tumor board, your tumor was less than 1 millimeter from margin, and Rex will say, yeah, but there was fascia there, yeah? So take into mind, was there fascia, right? That thick, dense collagen, that's an adequate plane, even if it's narrow. Margin status is important for local recurrence, as you might imagine. Did all of that make sense what I said? Okay. So margins, grading. So grading we do according to French system. So we take into account tumor differentiation. Does it closely resemble what we think of as normal mesenchyme? Not closely resemble, but I can histologic type it. Or is it completely undifferentiated or embryonal? How many mites are there? And how much necrosis is there? Not too bad, right? Honestly, the hardest part sometimes is this. Some tumors, if you can type them, already have differentiation scores. Otherwise, you sort of have to use your kind of your spider senses to figure out which it fits in. Grade predicts the probability of distant metastasis and long-term survival, right? Margins, local recurrence, grade, distant recurrence, and overall survival. So low, intermediate, intermediate and high generally being lumped together as clinically high for treatment purposes. Some tumors have a default grade. You don't really assign a grade because they are what they are, right? So things like myxoid liposarc, well-diff liposarc, low-grade fibromyxoid sarcoma, they are low grade. They don't have the potential to be intermediate grade unless they transform to their higher grade counterpart, round cell liposarc, right, D-diff liposarc, or sclerosing epithelioid fibrosarc. For those of you who are more advanced, these terms might mean something to you. For those of you who are learning, we'll get there eventually. Things that are by default high grade, also D-diff liposarc, right, round cell liposarc, rhabdo, Ewing's, alveolar soft part, epithelioid, clear cell. These are just biologically high grade, regardless of how many mitoses or necrosis they do or don't have. The current AJCC 8th edition stages tumors by T stage depends on site. So head and neck, trunk extremities, abdomen, thoracic, visceral organs, right? Not abdominal or thoracic cavity, but within a parenchymal organ, retroperitoneum, orbit, etc. I guess you attach to an organ, also fine. And sarcomas rarely go to nodes. There are some that do, and some of you who are taking boards, sometimes it shows up on your boards. You have a lymph node from a sarcoma that's positive. What sarcoma is it? It can be things like alveolar rhabdoepithelioid sarcoma, clear cell sarcoma. What do these have in common if you think about the morphology? They're all plump and kind of epithelioid. So there may be something in like a mesenchymal to epithelial transition of these sarcomas that when they obtain a more epithelial phenotype and can cluster and travel in a vessel, maybe they have more potential to get to lymph nodes. I rarely see spindle cell sarcomas in lymph nodes, right? The one osteosarc I saw in a lymph node was kind of plump and epithelioid, right? So just kind of an interesting thought experiment. And then of course, more often if you get a metastasis in a sarcoma, it's not going to be to a node, it's going to be to lung, right? It's going to be to some other soft tissue site or some other visceral organ or even bone itself. Questions? Okay, so we'll go over our basic concepts. So how do you look at an unknown spindle cell lesion? So we want to think about various things like cytoplasmic morphology, nuclear morphology, stroma, architecture, right? So let's start with nuclear morphology. And they all kind of mean different things. So when you're looking at kind of an oval nucleus with a small nucleolus and usually kind of wispy cytoplasm, right? That's generally a fibroblast or a myofibroblast. These may stain with a myogenic marker like SMA, Desmond. They may not. When you're thinking about smooth muscle, right? These often have these very sort of elongated cigar-shaped nuclei that don't have tapering ends, that have very dense kind of eosinophilic cytoplasm that is different from the stromal collagen, right? And so this is, yes, I'm a 5-year-old girl, my favorite color really is pink. So if you look at the pink, right, the pink of the smooth muscle cytoplasm, it's different, right, than the pink of the collagen. It might be a little bit paler or more baby pink, right? The collagen might be a little more magenta or like wavy pink, right? So you can tell whether you're dealing with cytoplasm or whether you're dealing with collagen if you look for that kind of tinctorial difference. Okay. Often the architecture of smooth muscle is a couple things. It's kind of 90-degree fascicles, right? So depending on how you cut this in the plane of section, fascicles might be coming at you and they might be going across the plane of the slide. So always look for that differential 90 degrees to look for smooth muscle. Sometimes, right, it's whirling off of a vessel, and that is also usually some kind of perivascular smooth muscle. Nerve sheath can be hard and can mimic smooth muscle, so sometimes we can't tell whether it's smooth muscle or nerve. Sometimes nerve has more wavy, right, or buckled nuclei with pointy ends. It doesn't really have that cytoplasm that you can differentiate from collagen. Like the background is just all kind of fibrillary and wispy. You may or may not see a fibrillary matrix like a Verriquet body. So sometimes we need immunostains to determine, but there are clues, right? Especially if the nuclei are pointy or wavy. So in terms of kind of stains, right, that we start with, right, we might want to start with an S100 or SOX10 for nerve sheath. We might want to start with something myogenic, meaning myofibroblast and smooth muscle all stain with SMA, muscle-specific actin, Desmond, calponin, whereas kind of only smooth muscle will stain with cal-Desmond and smooth muscle myosin, heavy chain, and myofibroblast will not. So that's one way to differentiate those two. So if you're thinking myogenic versus nerve sheath, that's one place to start. but we'll get into immunostains more later. That's just kind of step one. And as we said, fibroblast doesn't stain with anything. Okay, what about the cytoplasm? We already talked a little bit about kind of this wispy, polar tapered cytoplasm, which could be something like a fibroblast or a myofibroblast. What about if it's plump and pink and eccentric? So sometimes these are called plasmacytoid, right, because they resemble plasma cells, or rhabdoid because they resemble rhabdomyoblasts. Generally, rhabdoid being kind of really densely eosinophilic to resemble those myofilaments. Plasmacytoid tends to have, right, if it's a true plasma cell, it has this paranuclear Golgi haw, right? Or if the cytoplasm is just voluminous and the nuclei are plump and the cytoplasm is plump, right? This is kind of epithelioid, right? So we have epithelioid cells, we have plasmacytoid or rhabdoid cells, and we have these sort of stellate wispy cells. So sarcomas with the epithelioid morphology, like we talked about, not only are more likely to go to lymph nodes, but also more likely to express keratins or EMAs, again, probably because they have this mesenchymal to epithelial transition. So epithelioid sarcoma, classic, strong keratin expressor. EHE or epithelioid angiosarc, epithelioid nerve sheath tumor, malignant extrarenal rhabdoid tumor, sclerosing epithelioid fibrosarc. I guess we should throw in here synovial sarc is also a classic, right, keratin expressor, even though it's not necessarily epithelioid. Rhabdoid things can either be things that show plasma cell differentiation, because we see bone things all the time from multiple myeloma, right? So we see them on frozen, we see them on permanent. You have to be able to recognize that you may be dealing with a plasma cell, a true plasma cell neoplasm. Things that are rhabdoid could also have skeletal muscle differentiation, like Desmond myogenin, right? Things that are rhabdoid often characteristically have been described in this subset of tumors that have chromatin complex remodeling aberrations. So the INI1, the BRG1 tumors. So when you see rhabdoid or plasmacytoid, think true plasma cell, true rhabdo, or INI-BRG. And then subsequent, if those all don't work out, then we think from there, right? But always consider those three if you see rhabdoid. So that's cell morphology. What about stroma? Right, so stroma we see as either kind of fine, palish, bluish, kind of mixoid, right? Dense, pink, collagenous, sometimes heterogeneous, like osteoid, bone, hyaluronic acid, chondroid, right? So all of these terms imply sort of different lineages of differentiation. You can sometimes have heterologous stromal differentiation in tumors that are not primarily of these types. And don't worry, of course, again, we will get into that, but you advanced people can already start to think about the kinds of tumors that I'm thinking about. Okay. Like we know D. diff liposarc can sometimes have heterologous differentiation, all right? So that's one of those ones, for example. All right, overall architecture. I know we kind of went from nucleus back out, but that's fine. Usually we go from low power to high. This morning we're going from high power to low. It's fine. Okay. Architecture, haphazard, tissue culture, right? Again, this is fibroblast, myofibroblast, kind of non-specific pattern. We can have these whorls and these short fascicles that are intersecting, right? Sometimes called storiform. This might imply something like a fibroblastic thing, like a DFSP or a dermatofibroma or a perineurioma, right? So certain morphology implies certain histopathology. And then these long sweeping fascicles, right? If the long sweeping fascicles are very pale and hypocellular versus if the long sweeping fascicles are very dark and hypercellular, this may imply something different. But generally, this is either a fibroblastic, myofibroblast lesion, or sometimes something like an MPNST. But we'll get into these patterns when we get to each of the individual tumors. Just know that those are the patterns to be looking for. Vessels are also important, right? Not just stroma, not just architecture. In the books, you may read about this as HPC, right, or hemangioparasitoma-like, or staghorn. I like to describe them because if you don't know what an HPC is, or hemangioparasitoma, which doesn't exist anymore, right? Or you've never seen a stag, how can we describe them? They are thin-walled, they are dilated, and they are branching, right? So that's what that vessel is. So I like to use descriptive terms rather than some weird thing. Okay. Then you have these sort of thin anastomosing networks of capillaries, like here, that some people might call chicken wire, right? But if you've never had a chicken coop, maybe you don't know what a chicken wire is. So thin-walled, compressed capillary anastomosing. This is often seen in some sets of tumors, right? For example, here, myxoid lipoma. Then you have thick-walled or muscular vessels, which may imply some kind of hybrid vascular myogenic tumor. Or you might have these very, very striking curvilinear shapes, all of which imply different tumors. We always want to look for things like necrosis. This could imply malignancy. It could imply prior biopsy, so always check for prior biopsy. Or it could imply some other trauma. We often see necrosis in some benign bony lesions of kids that have undergone pathologic fracture, even if it's a benign bony tumor, right? So necrosis doesn't always mean malignancy, but it could. Mitoses also don't always mean malignancy. Rapidly growing things like nodular fasciitis can have tons of mitoses. Pyogenic granulomas, lobular capillary hemangiomas, right? Tons of mitoses, totally benign. However, not if they're morphologically atypical. It's tripolar, tetrapolar, right? All those things mean malignancy. And border. So something can be very circumscribed and be malignant, and something can be very infiltrated and be benign. But you have to notice it. You have to notice it because it may or may not inform your decision, because some characteristic tumors have characteristic borders, whether they be benign or whether they be malignant. So just notice it. Questions, comments, criticisms? Okay. And immunos. So there's a lot, right? There's a lot, and we will go through them when we work up the differential diagnosis of tumors on our service. But, you know, we generally want to think about broad panels. Keratins, right? We know that they can stain carcinomas or myoepithelial tumors, but they can also stain some sarcomas, right? Our neural crest and our melanocytic markers are overlapping, right? So S100 and SOX10, we know are for nerve sheath Schwann cells, right? But are also for melanomas, can also sometimes stain fatty things or cartilage things, right? Then you have your specific melanocytic markers that don't stain your nerve sheath, but may stain some of your hybrid melanocytic myogenic tumors. Myogenic markers, we already talked about a little bit in terms of how do they stain, and then vascular, right? And then other. For lymph, I don't know, I'm not a hematopathologist. I won't get into all of the hematopathology stains, but like, if you ever are uncertain, right, some things like a leukocyte common antigen or a CD45 may catch most of your hematopoietic things, most. I will never order Vimentin. I know that Vimentin is a stain that is used in the differential diagnosis of some very specific lesions. Like if it's Vimentin positive, it's cervical adeno versus squamous. I don't even know because I don't use it. But if you're using Vimentin in my world, you're basically asking, is the tissue immunogenic? That's it. If the tissue is staining for Vimentin, it is immunogenic. That is all I will say. I will not say that it's mesenchymal. I will not say that it's not epithelial. All bets are off. Okay, so we'll talk about each of these groups of stains in a little bit more specific. So keratins. So those of you who have, I think I mentioned this the other day to our resident, if you don't have that book, probably look into getting it or look into looking at it, because I think that book is very, very helpful for these kinds of differentials. When we think about keratins, we think about low and high molecular weight, and then sort of broad spectrum that has both low and high molecular weights in it, and then something like epithelial membrane antigen, which is the least specific. Low molecular weight keratin stains essentially non-squamous things, glandular, pan epithelium. High molecular weight stains things like squamous, urothelial, myoepithelial, right? So there's the difference between what low molecular weight will stain and what high molecular weight will stain. So if you're looking for a spindle cell squamous cell carcinoma, for example, you ain't gonna order CAM because it's never gonna be positive, right? If you're looking for a spindle cell squamous, you'll order something broad spectrum or something high molecular weight, right? If you're looking for something glandular, you may apply a broad spectrum and a low, okay? So just know what you're asking. We already talked about neural crest a little bit in terms of what S100 and SOX10 do, both melanomas, right? Both nerve sheath, specifically Schwann cells, not perineurial cells, right? Granular cell tumors, which we haven't talked about yet, myoepithelium, which we have talked about, fat, cartilage, and salivary pancreas acini with SOX10. So SOX10, S100 are no longer just sort of melanoma Schwann cell specific. We know that they do stain a lot of things, including some epithelial tissues. This is that Venn diagram, just broken down differently in a chart, right? So smooth muscle and myoepithelium are very similar, but myofibroblast immunoprofile is a little shrunk. Skeletal muscle is very shrunk, really for skeletal muscle, really Desmond. And your nuclear marker of skeletal muscle differentiation. In our lab, we have myogenin. MyoD1 functions quite similarly, but just have all that in mind. If you have, right, a spindle cell that you cannot prove is anything else by neither morphology nor immunoprofile, if it has none of these markers, it's a fibroblast. If it may have some smooth muscle markers, but not really all of them, and it doesn't look like smooth muscle, then it's probably a myofibroblast, okay? So just because something has SMA doesn't mean it's smooth muscle, right? Because it could be a myofibroblast. Okay, vessels. Cytoplasmic, right, CD31 and CD34. 31 being more specific than 34, which can stain all kinds of other fibrocytes and tumors. So if I'm going to pick one for vessel, I'll do CD31. I will also add on a nuclear marker, being ERG and FLY1. ERG also probably better than FLY1 because FLY1 can stain lymphocytes and other things in the background. So I tend to do ERG and CD31 with 34 and FLY as backups. Each of 40, of course, restricted to lymphatic endothelium. All of these others will be present in both blood and lymphatic vessels. But always check the background cells, right? Because these can have a lot of overlap. So things, right, like CD31 can stain plasma cells, FLY1 can stain lymphocytes. So look through the stain and look, that's why we have the blue counter stain on our immunos, right? We have the blue counter stain so that we can see the morphology of what those background cells are. You want to understand what cells are picking up what marker, because especially in these sarcomas, right, you can have a lot of inflammatory cells, histiocytes, plasma cells, whatever. So just check what's staining, because you don't want to call something a histiocytic sarcoma that is an undifferentiated sarcoma that just has a lot of histiocytes running around in the background. Okay, and then of course, molecular. So sarcoma, right, was the place where molecular, and of course heme, right, lymphoma, is the place where molecular started, right? We know a lot about molecular and sarcomas from cytogenetics, FISH, now next-gen sequencing. But as we do more and more and more sequencing, we realize that all anatomic subsites and all morphologies mostly have gene-defining mutations or fusions, right? So this is no longer just true for sarcomas anymore, as you've seen with us in the salivary and the thyroid, all of the other organs that I don't teach you, right? Many of these have immunostains that are predictive of that fusion or mutation. Some don't. we are very, very lucky in this institution to have the molecular lab that we do, right? That will basically sequence anything and will basically tell you anything, even if it's not validated, right? We found a plaque fusion, but it's not validated, so you can't use it for treatment purposes, but we found it, right? So like, awesome. So use that to your advantage for your assistance with diagnosis. Okay. If you have no idea what something is, what do we start with? A generic keratin stain, a generic nerve sheath / melanoma stain, maybe a general lymphoma stain, and there is no sarcoma stain, right? Because Vimentin is not it. How many times can I say it? So within sarcoma, right, maybe we want to start thinking about muscle, vessel, other, right? But we'll get there. If you still have absolutely no idea anywhere, we already just mentioned molecular, but you always want to have molecular in mind, not just when you're signing out the case, but when you're grossing it, because if you don't gross it right, you can't get good molecular. I know this doesn't apply to you guys anymore because you're not doing biopsies, but when you see how many times I get called from the gross room, Dr. Cipriani, I have a question on how to gross this biopsy. I got 5 cores ranging in size from 0.3 to 1.3 centimeters. How do you want me to split these out, right? Multiple times a day we get that call. We like to split the cores into multiple blocks, right? Because if you shove them all in one block, you do 30 immunos, you have nothing left for molecular, right? If you split them out into 5 blocks and you do 30 immunos on one block, you still have all the other blocks left for molecular, right? So split them out into a reasonable number of cassettes. 3, 4, 2, depending on how much tissue you have. If they are calcified and they are core biopsies, for a core biopsy, we always try to do them undecalcified, or if they need to be decaled, EDTA only for core biopsies, because HCl destroys nucleic acids and you cannot do FISH, you cannot do sequencing. So when you go out into practice, if your lab doesn't have doesn't have EDTA, just buy the jug. It's easy. It takes longer, as you guys know, but it is 100% will preserve your nucleic acids. If you are not dealing with a core biopsy, right, and you're dealing with a larger resection specimen, what do you have to ask yourself? Was there a prior biopsy that we have tissue on that was not decalcified? And how much of the current large specimen can we extract not decalcified? Because if you have tumor adjacent to bone or tumor in bone or calcified and non-calcified portions of tumor, you always want to isolate some of the non-calcified non-osseous tumor for non-decalcified tumor sections, right? So if you can take any non-decalcified, take it. If you cannot take any non-decalcified, like it is an extremely ossified osteosarc or something, you want to segment out pieces for EDTA decal and pieces for HCl decal, so that you have tissue that you can do molecular on, but you also want to get some cases that you can see with histology, sooner, because EDTA is going to take longer, right? So always priority, undecalcified, EDTA decalcified, HCl. Does that all make sense? All right, just always ask yourself that when you're grossing. We've had issues in the past where entire 10-centimeter things have just 100% been thrown in HCl, and like that is useless because you've lost it all. It's gone, right? So always think before HCl. Right here we do a lot of DNA RNA-seq, which will of course find your mutations and your fusions with your RNA, copy number changes, microsatellite instability, tumor mutational burden, right? These are the main things that they report. Interestingly enough, with tumor mutational burden, right, what can they do with a high tumor mutational burden? They can plug it into the cosmic database. You molecular pathologists tell us more about this, right? And come up with, does it have a signature, a UV signature, a tobacco signature? This will help tell us a little bit more about the etiology of the case as opposed to just DNA mutation, right? So all of these things are helpful. Sometimes if you are like 99%, I think this is this tumor and I think it has this fusion, maybe then we'll do targeted FISH. And those of you who have been on the BST service know we have limited FISH in-house, but our colleague Julia Bridge, we send a lot of cases to her for custom kind of lower frequency FISH probes, EWSR, MDM2, yada, 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 mammal. Okay. All of this has to be done on non-decalcified or EDTA. Okay. Questions? Okay. It's like 8:52. Now we have 8 minutes. We can get into some of the morphologic differentials. We can stop. We can go get coffee. What do you want to do in the next 8 minutes? The first years picked this presentation, so how about the advanced pick something else?
It's hard to do a lot. 7 minutes.
Let's see what's on the next slide.
Yeah,
And then we'll decide.
Okay,
that will rule us.
Let's do it.
yeah,
Let's do it.
fat, okay. So fat comes first, because fatty tumors are probably one of the more common tumors you're gonna see. You're gonna see lipomas, and you're gonna see D-diff liposarcs, and you're gonna see well-diff liposarcs, and you're probably gonna see some weird thing like a hybrinoma or a fibrolipoma or a whatever. Okay, so we'll do that. How do we think about fat? A normal fat cell is, moderately sized with a kind of plump biprecentic nucleus. This is different from brown fat, right, which has multiple cytoplasmic vacuoles like a little pretty flower, but a plump nucleus in the center. Lipoblasts are sometimes smaller and sometimes bigger than normal fat, but should have indented nuclei, right? So that's a lipoblast. Whether it be signet ring, it pushes the nucleus aside, whether it be sort of bivacuolated and creates 2 indents in the nucleus, or whether it be multivacuolated and somewhat pleomorphic and have multiple indents in the nucleus, right? So those are lipoblasts. Fat necrosis can mimic atypical fat because it sometimes looks shrunken or shriveled. It sometimes looks like it has vacuoles, but these are the cell membranes like collapsing. But you don't really see nuclei, right? You don't really see nuclei of fat. If you see nuclei, those are histiocytes, right? So look at the cytoplasm and look at the nuclear morphology. You may be seeing fat necrosis with histiocytes. If you happen to cut a fat cell in a specific plane, you may see these large nuclei with intranuclear vacuoles. These are called Lockhern cells. These are normal benign fat. You just happen to see them in the plane where they catch this vacuole. The contours should be smooth. The chromatin should not be very dark. And you'll see these vacuoles. We also talked about fat necrosis. The one thing I will say for you advanced people is that MDM2 CDK4, when you're looking for liposarc, histiocytes and multinucleated giant cells can stain with MDM2, so just be careful of what you are looking at. Benign fatty tumors are all listed here in terms of the most common thing you'll see is lipoma. You may see hybrinoma, which is a tumor of all brown fat, right? You may see an angiolipoma. So some of you have gotten stumped on this. Multiple forearm, painful, younger person. Check for the capillary vascular proliferations and check for the fibrin thrombi. And so if you ever see multiple lipomas in the extremities, think about angiolipoma. Lipoblastoma basically has to be present essentially since birth. It can look like it has lipoblasts. It can look like it has myxoid stroma. It can look like it has these fibrous septations. It can mature into essentially a benign looking lipoma and only have residual kind of septae. So think about a young person. And spinal cell or pleomorphic lipoma, which sometimes has a lot of fat and sometimes only has a little fat and sometimes has hardly any fat. But these have prominent, very blunt-ended, bland spindle cells, and is defined by genetically loss of retinoblastoma. So we do have retinoblastoma, IHC. Of all of these, this is kind of the only one in which I will use IHC. The rest are H&E diagnoses for that. Spindle cell is often on the posterior neck or back, but can be kind of anywhere. It has a spectrum to this so-called pleomorphic lipoma with these little rosette-like cells that can mimic atypical lipoma. Of course, the difference is that these will have loss of retinoblastoma and will not have amplification of MDM2 CDK4. So you can use that. CD34, I know, has characteristically been described as positive in spindle cell lipomas, but I think CD34 is positive in a lot of fibroblasts, so I kind of tend to prefer the nuclear markers. Okay. What it does not have is they're not hyperchromatic, they're not angulated, they're sort of vesicular, nice, open, kind of, not open, but pale nuclei and smooth contours. As opposed to, we won't get into that, as opposed to, right, your atypical lipomatous tumor, which has dark nuclei and angulated borders. Okay. So when we think about the fatty tumors, it's kind of like, are they benign? Do they have a locally recurring but non-metastatic counterpart, right? So this intermediate kind of category. Do they have a high-grade, malignant, potentially metastasizing counterpart? And what is their genetics? And generally, you can split the critically, clinically important fatty tumors into these boxes. So it's either just a totally benign lipoma, it's either a spindle cell or pleomorphic lipoma, or one of these atypical spindle cell pleomorphic lipomatous tumors that have some increasing cytologic atypia, but none will metastasize, and they all have a retinoblastoma loss. Then you have atypical lipomatous tumor or well-diff liposarc, whether you're in the trunk extremities or the retroperitoneum. That's already a low-grade sarcoma, essentially. If it goes bad, it's D-diff liposarc. They all have MDM2 CDK4 chromosome 12 problems. Myxoid liposarc is your low-grade counterpart. Round cell is your high-grade. They all have 1216 FUS DDIT3. And then you have pleomorphic liposarc, nasty, ugly, horrifying, does not have this, does not have this, and does not have this. So it's this, right? Okay. General framework for fatty tumors. They're not, you'll see that, you will 100% see them. They are everywhere, and you can kind of box them in, which is pretty good. This is kind of generically what they might look like, and we'll talk about them, but it's 9 o'clock. So if you want, I can briefly go into the morphology if you want, since we're already here. Should I go? Okay, I go. So well-diff liposarc versus atypical lipomatous tumor, as I said, it's just location. So in the trunk and extremities, atypical lipomatous tumor, because you excise them and you watch, done. Sometimes they dedifferentiate, mostly not. In the retroperitoneum or the head and neck, small, tight, critical spaces, or the spermatic cord and paratesticular region, right? Because what is that? It's retroperitoneal fat pulled down from the gonadal vessels. Those are all liposarcs. We don't call those atypical lipomatous tumors. They all have these hyperchromatic and large angulated cells within fat. They sometimes have variants that are highly sclerosing, so you might not see any fat. They also have variants that are inflammatory, so you might see a ton of associated inflammation, but you will always see the enlarged, dark, angulated, pointy, ugly looking stromal cells, whether or not you see fat or not, right? So always think about liposarc, even if you don't see fat, if you see those kinds of cells, and throw your MDM2. And if they're positive in those cells, you have an answer. Right, D-diff, you basically lose the fat, you gain hypercellularity, and you gain mitoses. Now you're high grade. Okay, but MDM2, CDK4, or in the time of cytogenetics, how did we figure these out? Chromosome 12 had these like giant giant chromosome 12 that were either long rods or they stuck together and they became these rings. So that's chromosome 12 problem. Myxoid round cell. Usually this is of younger adults. Usually this is in the extremity, and it looks, again, these kind of curvilinear thin walled blood vessels with lipoblasts, right? So you should see lipoblasts in myxoid liposarc. You should not see those hyperchromatic angulated ugly stromal cells, right? These cells are actually quite bland, right? In contrast, right, well-dipped liposarc, you probably won't see lipoblasts. So don't go looking for them. You will see those cells, right? So atypical cells, usually no lipoblasts. Bland cells, vessels, lipoblasts. Okay, that's myxoid. Myxoid can go bad in the form of round cell, right? So what it does, it starts having hypercellularity, and those cells look like these little plump, like almost like a small round blue cell tumor, right? Sometimes with nucleoli. So if you're looking at a small round blue cell tumor, you can also kind of think about maybe a round cell liposarc. The fusion is diagnostic, right? CHOP FUS or DDIT3 FUS. If you see something like this or this or this in the retroperitoneum, what is it? It's either a metastasis of a myxoid round cell from the extremity, or it's a myxoid round cell like MDM2 problem, right? D. diff liposarc, okay? This does not occur primarily in the retroperitoneum, but your well-diff D. diff liposarc spectrum can look like this in the retroperitoneum, okay? I have to say this multiple times because it's a pitfall. If it's truly myxoid round cell with that rearrangement, any round cell component greater than 5% is thought to be bad. Lastly, pleomorphic. Also generally in the trunk and extremities, but now of older people. Super nasty, nasty lipoblast. Like this is not a diagnostic problem. You have tons of spindle cells, tons of mitoses, tons of these pleomorphic lipoblasts. Sometimes they're signet rings, sometimes they're multivacuolated. If you see this in the retroperitoneum, what is it? Dedifferentiated liposarcoma. If you see this in the retroperitoneum, it is a pleomorphic liposarcoma like D. diff liposarc, all right? Retroperitoneum is always this, generally, 99% this, okay? So, trunk extremity. If it's in the retroperitoneum, do the MDM2. Even if this is in the trunk, do the MDM2. So you can prove that it's not a pleomorphic liposarcoma like D. diff. Because prognostically, those are different. It's thought that the well-diff D. diff may be a little bit better than this. So just always do the MDM2. What is my lesson? Just always do the MDM2. Don't do Vimentin, do MDM2. Okay, so complex karyotype, no specific genetics, no MDM2, no CHOP FUS. Okay. That's a comparison of all of them. Because I love charts. Okay, I'll stop. You'll have to tell me for January how you want to continue. We can do some unknowns, we can do more of this. So just think about it and let me know. Okay. Hopefully that was helpful. Okay. Thank you. Wonderful.
Have one minute.